with patients that may have a psychiatric condition called body dysmorphia, which we think is 10% of most of the patients we see. I think a doctor has a responsibility, if a patient is doing too many treatments, to probably not offer any more treatments. A doctor should have a responsibility not to cross the ethical lines of what he considers is an appropriate result. The optimal corrections are often just restoring symmetry to a face, and often the best results are when nobody even notices it. So I think if you do good aesthetic work, it shouldn't be very obvious on a patient's face. So a good esthetician is very like an artist or a sculptor, and they're often left-handed, and they often follow the symmetry of the golden ratio in their own minds. The optimal result should be when somebody looks at somebody and say, "Oh my God, you look very well," but that they shouldn't look overdone or they shouldn't look asymmetrical. Thankfully, the ones that are the most dangerous probably happen the least often. So the ones that happen most frequently tend to be things like bruising, swelling, and as you use better fillers, then these problems tend to be less. And if you screen your patients not to be taking aspirin or vitamin E or omega fish oils, usually your complications rate in terms of bruising goes down dramatically. The next problem we see is delayed onset nodules, which normally happens about 3 months, and the patients get lumps within their face. Probably the next often then is biofilm, where the patients can get an infective layer growing upon them. Thankfully, the least often is vascular occlusion, but obviously vascular occlusion is the most dangerous, and this can lead to blindness. Okay, I suppose it all depends what complication it is and what complication or which filler product. If the complication at worst is a hyaluronic acid induced vascular occlusion, the first thing to do is massage the area, heat the area to induce some level of trying to move the embolus further along the line, and then probably to introduce hyalase at high dose fairly quickly. Most complications, if they're got early, can be reversed very early. I have advocated the use of 750 milligrams, of international units of hyaluronidase now for many years, for at least 6 years, and thankfully everybody's moving from 75 to 750, which is nice to see. Then other things come into play. You try and induce vasodilation by the use of nitrates. We're moving now more towards oral nitrates like Viagra or Cialis, rather than topical nitrates, which have been shown to show paradoxical problems where the vessels are opened in the area and the embolus apparently becomes exaggerated to an extent. The use of hyperbaric oxygen is still disputed to a large extent, but I still use it quite widely.